Good afternoon. My study is Profile of Refractive Status among Infants in a Tertiary Eye Care Center in South Kerala. Introduction. Refractive status in infants refers to how the eye focuses light on the retina. At birth, most infants are mildly hyperopic due to small size of eye. As the eye grows, a natural process called emetropization occurs. Aim of the study to evaluate the prevalence and pattern of refractive errors among infants and to identify associated risk factors. Materials and methods. It was a retrospective analysis in a tertiary eye care center, including 260 infants in 1 year duration of time. Inclusion criteria, all infants who underwent comprehensive ocular evaluation. Exclusion criteria, infants with media opacities, prior ocular surgeries. Methods, detailed account of prenatal, natal and postnatal events, age of presentation, presenting complaints, dilated refraction was done, ocular alignment and motility, anterior and posterior segment evaluation. Results, among 260 infants, 51.2% were female and 48.8% were male. And the most common presenting complaint was squint in among 41.2% infants, followed by redness, and others were follow-up of ROP, routine checkup, and NLDO. Refractive status, 32.3% were emetropic, and among refractive errors, hypermetropia was most common, seen in 38.1% infants, followed by astigmatism and myopia. And the risk factors which was involved was family history in 15% of infants, followed by delayed milestone in 12%, and neurological history in 5% of infants. In both family history and developmental history, more than half of infants showed refractive error. And coming to gestational age, 64.2% infants were born at term, and 35.8% were preterm babies. And among term babies, 59% had refractive error, and among preterm babies, 74% showed refractive error. And strabismus assessment, 58.8% babies were orthophoric, and 35.4% had squint. Among squint, 27.9% had exotropia, and a smaller proportion with esotropia. And among orthophoric babies, 56.9% had refractive error, and among squint babies, 84.1% had refractive error. Overall, the preterm and infants with squint and with family history showed a higher proportion in developing refractive error, but also term babies, orthophoric babies, and infants with no risk factors also showed a higher prevalence in developing refractive error. Coming into the significant refractive error, of 99 infants with hypermetropes, significant hypermetropes with squint, that is greater than plus 1.5 diopter, was 14 in number, and without squint, that is greater than plus 4 diopter power, was 5 in number. And significant myopes were greater than minus 3 diopter power, had squint during presentation, and they were 5 in number. Astigmatism was observed in 20.4% infants, with no cases exceeding 3 diopters. And among significant refractive error babies, 8 infants were given glasses, 16 were advised patching, and all others were advised for routine follow-ups. Discussion. So this study revealed that considerable number had refractive error even during early life. More importantly, healthy term babies, orthophoric babies, and infants without any family history also showed a high prevalence of refractive error. It highlights that relying only on history or obvious clinical signs will miss many infants with significant refractive error. So all infants should undergo a dilated retinoscopy screening regardless of their complaints and histories. Also notice prematurity, family history, and strabismus increase odds of refractive error, and they should be provided with optical and therapeutic intervention and also for regular follow-ups. And comparing with the study of OA et al. Of 583 infants in a study period of 1 year, the most common refractive error was hypermetropia, followed by astigmatism, while genetic and prenatal environmental factors contributed to early onset myopia. Conclusion. Early screening of an infant is essential to identify and analyze refractive errors, prompt detection and appropriate optical and therapeutic intervention to prevent future amblyopia and squinting, parental counseling and adherence to regular follow-ups to ensure proper visual development and prevent progression. Take-home message: early eye checks builds a foundation for a lifetime of clear vision. These are my references. Thank you.
Don't you think it's too radical to screen all the infants with refraction? Your advice, you said all the infants should be screened for refractive error. So do you think it's a practical idea to screen all the infants?
Since this study showing a considerable amount of infants with no risk factor also showing a refractive error, it's
So what do you expect in an infant? Even normal infant, if you do refraction, whether the infant will be emmetropic normally, or the
No,
infant
no physiological refractive error will be seen.
yes, the most of the hyperop that you diagnose, that's a natural part of growth of your eyes. You know? And if you see the school vision eye screening program, the age group is 6 to 8 year.
Yes.
So have you ever thought why 6 to 8? Why not 3 or 4? Because of the same issue. Because your eye is not fully developed. If you do a refraction, there will be refractive error. But that doesn't mean all the kids has to be prescribed glasses. So the benefit ratio, the risk benefit ratio, or the amount of investment that somebody is going to put to screen all the babies is too high for the government of India. Okay? So I think this is little overstretching. If you should screen all the infants for refractive error, you can say if an infant has these symptoms or this not showing interest in play, all this, then they should be screened. I don't think it's practical to screen all the infants.
Sir, -8 was highest. Uh, uh, like among out of 8 infants with given squint glasses, 5 had family history, strong family history. Most of them MI. Thank you.